and it's actually a mitral clip case. Over the next 10 minutes, we'll go through some of the details of this case, okay? This is a 63-year-old female with dilated cardiomyopathy. Thank you. Which she had for many, many years. You can see the numbers dictating severely dilated left ventricle and significantly reduced ejection fraction. She also had significant mitral regurgitation, functional, with the numbers that you can see here, regurgitation fraction of 63% with an ERO of 28 and a regurgitated volume of 52 mLs. She also had a recent hospitalization for acute pulmonary edema. She did not have any coronary disease, and that was verified once more. Comorbidities included paroxysmal atrial fibrillation and type 2 diabetes on oral medication. The patient was evaluated from our heart team, and she was enrolled in the randomized Reshape Heart Failure 2 study, which is a European study looking at patients with severe functional mitral valve regurgitation and randomizing patients to either mitral clip or optimal medical therapy only. And this is an ongoing study. So we'll go ahead with the presentation with the AVI folder. So we'll go ahead to our first, we actually truncated a bit the presentation, so we'll go ahead with our, this is, once we got into the left atrium with the cerebral guide catheter, we have these hemodynamics where you can see the V waves in the order of about 20, about 30 for the peak V waves, suggesting significant mitral regurgitation. We'll go ahead with, να προχωρήσουμε λίγο ακόμα στο επόμενο. So we have already inserted the cerebral guide catheter. It's stabilized in place. Here we are, you have to go back. Πήγαινε πίσω, στο προηγούμενο. Παρακαλώ, στο προηγούμενο πήγαινε πίσω. Πίσω. Okay. So here we have the mitral clip being advanced through the cerebral guide catheter into the left atrium. Παίξεις παρακαλώ. Παίξεις. Okay. And we can see the echo image, the corresponding echo image on the left upper frame. The clip delivery system is secured on the table. And gradually we have the insertion of the clip into the left atrium under careful echocardiographic guidance to avoid any interaction with the walls of the left atrium. And once we're straddled, we're waiting for the straddling to take place, for these two markers to go right at the edge of the cerebral guide. We're heading into the pulmonary vein. We're very close to the wall there, so we're going to be pulling back on the cerebral guide to provide some more space. We're almost straddled here. Once we're straddled, we'll be able to do our maneuvering towards the mitral valve. Already been giving some posterior direction and some on the device, and pulling back a little bit on the guide sheath, on the guide catheter, and now rotating towards the mitral valve. And looking here in a commissural view alongside with the long axis, corresponding long axis view, try to get a sense of our trajectory, of our being exactly over the maximal jet of mitral regurgitation, which in this case was a white jet across the coaptation zone. The patient is now sedated, so it doesn't appear that much, but with the patient not sedated, we had significant mitral regurgitation. So the trajectory here is central, medial lateral, we're on the center. We're facing a bit posterior, but overall, it's a good place to start our efforts. Our plan here was to implant a clip right at the center of the valve, maybe slight more medial, and see how that affects the degree of mitral regurgitation. With the plan to if there was significant MR from both sides, then to implant the second device. So here we see the trajectory moving in the medial side, so we have to correct for that. We don't want to go into the papillary muscle and the chordae that sit below the medial commissure. So corrective measures are taken to have a trajectory right at the center of the valve, aiming towards the apex of the left ventricle. And trajectory will be reassessed again. And now we've opened the device and we look for perpendicularity. They obviously were very parallel to the coaptation zone, so obviously we're going to be rotating the device counterclockwise to be perpendicular to the coaptation zone. Some acoustic shadowing falling off from the catheter over the anterior arm. So moving in the probe a little bit will help us be able to see both arms at the same time. And we're fairly perpendicular, maybe slightly slightly clockwise now to come a bit more perpendicular to the valve, minor adjustments. And once we are happy with that, then we are positioning ourselves to cross the valve and we've established that this is a good angle to see both arms of the device open prior to entering the left ventricle. It's a good area with color. So a reasonable place to position our first clip. And here we are advanced into the left ventricle. Here we see the device through the mitral valve, and we bring down the gains. We can sort of reassess the perpendicularity, which appear to be probably okay, or maybe slightly clockwise, but here we have our first grasping. Both leaflets are on, and we can see the grippers falling down and closing the arms of the device. And we will reassess the color based on what we have now. And we have a sense here that there may be an eccentric jet of IMR coming from the medial side in this direction. So that sort of puzzled us a little bit. We had some reduction in the degree of MRs. Definitely there's this lateral jet which is far away, and we probably considered a second time, maybe for a second device. But here our concern was whether we were distorting the valve and causing some eccentric MR where it was not there before. Looking at 3D, we may have you see this eccentric jet being more prominent here, moving in this direction, which was something new. When we see that, we always are concerned about whether we are positioned exactly perpendicular or we are distorting the valve in one way or another. So our decision based on this was to reopen, reassess perpendicularity, and go ahead and slightly reposition the device. And here we're evaluating this again. As a tissue bridge, it looks okay, but we were concerned about the color that was coming from this medial side. So maybe bringing the device a bit more vertical would be what the patient needed. So here we've opened up the device and we do a second grasp in an area that's near the previous one, but we've rotated the device a bit more clockwise. And now we'll see the color that we have in the tissue bridge that we've created. First of all, we wanted to see symmetry in how we grasp, and it seemed to be okay. We didn't have any particular concern about symmetry this time around. And next we would be putting some color on the image to see how that looks and how much we reduced the MR. And indeed, we see that we have a much significant reduction, and this eccentric jet that we saw in the beginning is essentially not there. Very small jets from each side of the device, and this is with a blood pressure about 130 systolic. So we were very happy with this result, as well as the grasping of the leaflets that we were going to proceed with releasing this device as is. We would also check for the mitral valve gradient before we do, obviously, any releasing of the device. If I remember correctly, the mitral valve gradient, let's see, it was about 4 to 5 millimeters of mercury. And we will be measuring this. So based on that, it was about 5 millimeters of mercury for the mean gradient. So based on that, we decided not to proceed any further with any further devices. There was a small jet laterally, but we did not consider that to be clinically irrelevant. So with that result, we decided to, also it was a very lateral jet here. So we decided not to proceed any further with any more devices and concluded the procedure there. With releasing the device after ensuring that both leads were correctly attached. We can go to the next. And this is where we were evaluating the degree of leaflet insertion. And the best measure for evaluating that is to actually have a good documentation of the grasping sequence, and that's what we had here, very clear, crisp images showing the whole posterior leaflet, anterior leaflet, all the way in, and that was reassuring to us that we were going to have a fine result from leaflet capture. And concluding the procedure, this is the release phase of the procedure. And we evaluate the color once more and whether anything has changed. Very stable position for the device. And final evaluation of color. Here we've removed the clip delivery system. And a small jet from either side, very clinically insignificant jets, we would say. The procedure essentially concluded with removing the cerebral guide catheter and had no complications. And with this, this is this case that we presented. And if you have any questions, by all means. Thank you very much.
Excellent presentation, excellent talk, Mr. Chrissoheris, as usually. Thank you. We have run out of time, but if anybody has a very small, very short comment or question, please go ahead. There is no question, no comment. Thank you very much. There is a very short break of 5-10 minutes.